Every day, you inhale thousands of microscopic fungal spores without realizing it. Among them are mucorales, the organisms commonly known as bread mold fungi. They constantly thrive in the soil, on decaying vegetation, and in the air circulating around us. For a healthy human, breathing them in means nothing. Your immune system easily recognizes the foreign bodies, and specialized cells known as macrophages simply swallow the spores up and dissolve them before they can germinate. Historically, the diseases caused by these fungi were grouped under the broad term Zygomycosis. But as modern medicine refined its clinical classifications, this specific, highly lethal threat became known by its accurate name, mucormycosis. The danger emerges when the body's defensive shield fails. If a person suffers from internal immunosuppression, like poorly controlled diabetes, or severe physical trauma, these otherwise harmless environmental spores recognize an opportunity. Unchecked, they transform into aggressive pathogens. Mucormycosis is a disease of opportunity. The threat exists in the sudden collision between an omnipresent environmental mold and a momentary lapse in human biological defense. There are two primary pathways these spores use to bypass our defenses. The first is an internal failure, where a chronic illness disarms the immune system. The second is a brute force breach, severe external trauma. When catastrophic natural disasters like tornadoes tear through a populated area, the sheer force of the wind weaponizes the environment. Survivors are left with deep lacerations packed with splintered wood and soil, the exact materials where these fungi naturally thrive. A similar breach occurs in the aftermath of massive tsunamis. Victims with open wounds find themselves submerged in stagnant, contaminated water, surrounded by rotting wreckage. In the immediate aftermath of these events, medical resources are stretched to their limits. Inside overwhelmed triage tents, while doctors focus on stabilizing traumatic injuries, the fungal spores quietly germinate in the open wounds. What begins as a standard contaminated laceration rapidly accelerates. Escaping the notice of a distracted or compromised immune system, it develops into one of the fastest-spreading fungal infections known to medicine. In the wake of mass trauma, survival hinges on time. The biological clock starts ticking the second the fungus breaches the skin and enters the bloodstream. Once inside, the infection usually establishes its beachhead in the paranasal sinuses, the nasal cavity, or directly within deep cutaneous wounds. From there, it expands physically. The fungus grows broad, ribbon-like structures called hyphae, which act like microscopic roots forcing their way through human tissue. These hyphae demonstrate a predatory affinity for the vascular system, specifically seeking out and encircling the walls of the host's blood vessels. This invasion causes a condition called thrombosis. The physical presence of the tangled fungal branches inside the veins completely blocks fluid flow and triggers the formation of solid blood clots. With the blood supply cut off, the surrounding cells starve of oxygen. This leads to rapid, irreversible tissue death, presenting on the patient's skin as a painful black necrotic crust known as an eschar. The pathogen effectively turns the body's own plumbing against itself. By converting life-giving blood vessels into starved dead zones, the fungus secures a pathway to expand outward, often moving directly toward the brain. This hyper-fast expansion creates a severe clinical dilemma. The infection spreads at extreme velocity, yet the tools available to confirm its presence are agonizingly slow. Standard laboratory techniques will often yield nothing. Indirect blood tests frequently fail to detect any trace of the fungal DNA circulating in the patient's system. Physicians must search for secondary visual evidence. They scrutinize CT scans for the reverse halo sign, a specific lung pattern that signals the presence of the invasive pathogen. To get definitive proof, they must fall back on the gold standard, surgically extracting a tissue biopsy. The sample is treated with potassium hydroxide, allowing pathologists to manually look under a microscope for hyphae branching at distinct 90-degree angles. This is the deadly friction of mucormycosis. Every hour spent in the laboratory staining tissue and waiting on cultures is an hour the necrosis steadily advances toward critical anatomical structures. To halt the spread, doctors immediately administer intensive intravenous antifungal drugs, relying heavily on a potent medication called amphotericin B. But pharmacology alone often fails. The intravenous drugs travel through the bloodstream, but abruptly stop at the edge of the dead zone. Fungal thrombosis has already destroyed the blood vessels required to deliver the medicine. Thus, medical teams perform severe surgical debridement, the aggressive physical excision of all infected tissue. In cases where the infection has rooted in the limbs or the face, known as myocutaneous or rhinocerebral infections, this procedure is devastating. Stopping the spread frequently requires the amputation of limbs or the total removal of the palate, the nasal structures, and the eyes. These disfiguring measures are an absolute clinical necessity. They represent the final physical barrier preventing the fungus from breaching the central nervous system. This leaves doctors and patients facing a brutal calculus. To survive mucormycosis, you must outrun it. When the drugs fail to penetrate the dead zones, the only way to win that race is the rapid, irreversible sacrifice of infected flesh to outpace the expanding necrosis.